Thank you. Visiting lovely Venice from Washington, D.C. My name is Guenevere Burke. I'm at the George Washington University, and I work closely there with Fitzhugh Mullen, who I think is familiar to many of you and whose work was cited earlier today. We do a lot of work in health policy education, but the other half of my work is spent in telemedicine. And I think, as many others who are going to speak this afternoon, I'm really excited about the potential of technology to transform the way that we provide care. And I'm going to share a little bit with you about what we're doing in terms of telemedicine and emergency care. So why are we talking about telemedicine? Certainly, telemedicine isn't a brand new technology. It's been used for decades. Why are we talking about telemedicine at a conference on innovations? Is this really an innovative way of providing care? They've been doing remote telemedicine in Australia for 20, 30 years. We've had programs in DC since 1989. I would argue that telemedicine is timely to discuss now because while there's very exciting new adjuncts in technology, cool things you can put into your iPhone case that will do an EKG tracing, tell you your vital signs, virtual stethoscopes, otoscopes, all of those things, and even an ultrasound that can just be hooked up to your phone. Really, what's most exciting to me about telemedicine is the opportunity to dramatically expand patients' access to care. So this is something that we see and feel very acutely in the emergency department, or patients' limitations in follow-up and access, and we're not alone. So we've made incredible advances in insurance coverage with the Affordable Care Act in the US, but that doesn't mean that all of our patients have access to care, first of all. Insurance doesn't mean access all the time. It also doesn't mean that they have timely access to care. And I think this is truly the promise of telemedicine, our ability to expand our capability to care for a large number of patients who may not otherwise be able to seek care when they need it. So emergency medicine has grown tremendously over the last 20 years or so. And this may change in the coming years as health reform expands insurance coverage. But certainly, it's growing at twice the rate of population growth. Why are we seeing that? At this conference, like so many others, I hear about the laudable goals of public health and prevention. We need to keep people out of the ER. It's not working. Why are people coming to the ER in such high numbers? It's obviously a very complex issue, and I don't want to oversimplify it, but we know that the majority of people who are coming to the ER have a primary care doctor. They have a usual source of care that they can go to. So why are they there? About 40% of ER visits, maybe more, depending on the source that you're using, are for non-urgent or certainly not emergent conditions that could be handled elsewhere. So I was talking earlier about timely access to care. We certainly know that that's one issue. But I would argue that another reason why people are seeking care in emergency departments is that despite the fact that it's chaotic and wait times can be long in large urban centers, it's really a form of very patient-centered care. We bring everything to the patient, the nurse, the doctor, the technician, sometimes the whole x-ray machine. We bring everything to the bedside to provide care to the patient when they need it, when they want it, in the middle of the night, and provide them with rapid answers. So not only are patients choosing to come to the ER, but often they're referred from their doctor's office to the ER, simply because we can get things done so very quickly for them, and they want rapid answers. So in terms of the issues that we're facing with access to care, we're clearly not alone. A number of people have come up here and talked about the maldistribution of physicians and some of the challenges that people face regarding access. So this is a study from the Commonwealth Fund in 2013, evaluating patients' ability to access care when they were sick or felt that they needed it. So certainly you can see in the US on the far right that we're struggling more than most. So less than half of our patients feel that they can get, or reported that they were able to get, a same day or next day appointment when they needed care. And almost a quarter, over a quarter, had to wait 6 or more days to see somebody. And while other countries, notably Germany, are doing much better, these challenges exist across the board. So when someone does get in to see their doctor, what is their experience like? I really enjoyed reading through this report from the American Journal of Managed Care that says that the average patient takes about 2 hours in the whole process of going to see the doctor. So that's including travel time, time spent in the waiting room, and then just 20 minutes with their physician. And this same group of researchers looked at the experience of different minority populations in the US that have traditionally been underserved. And this is also an issue of equity. So not surprisingly, those minorities that have been traditionally marginalized had longer wait times, arguably can afford the time away from work even less, and also face greater burdens of disease. So this is what patients face when they actually do make the time to get an appointment and get into the office to be seen. So what we're doing at GW is in our Department of Emergency Medicine, we formed an innovative practice group, and we're really looking to develop telemedicine solutions for some of these patient problems. So timely access to care and patient-centered care. As I mentioned, we have our roots in what we call our Maritime Medical Access Program. So this is a program launched in 1989 and still very active today. This is a program where we provide medical support largely to commercial shipping vessels. So vessels in remote areas of the ocean who have limited access to resources, and we're providing consultations to them by video, store and forward of photography, medical photography, and by low bandwidth video. So that's how we got our start, and that's how much of telemedicine started, in improving access in rural and remote locations. But that's not where we are anymore. So what you see in terms of the map is the District of Columbia and the variations in life expectancy based on place of birth. So you can see that they vary. So in the northwest part of the city, traditionally the wealthiest part, they enjoy the longest life expectancy. And in the southeast, traditionally the poorest part, it's fewer years of life. This is a reflection of the maldistribution that exists not only between countries, within countries, it's also within cities. So even in our urban areas where there's no shortage of doctors and certainly no shortage of specialists, those in the southeast area will still struggle to get timely access to a physician, and certainly to a specialist is the greatest challenge. So our most recent grant is to develop telemedicine access for these patients to see specialists in endocrinology, cardiology, and nephrology in their convenient places of care in Southeast DC. But I've been asked to talk with you today about our Connect ER program. So I'm going to shift. If you visit our website, this is what you'll see. This is our Connect ER program is a telemedicine follow-up program for patients that have recently been discharged from the emergency room to connect with a doctor online. So we're often asking patients to be seen within just a few days, and we know that that's going to be incredibly challenging. So this is another option. They'll receive information about the program in their discharge instructions, and they can also access us online. So when they call or email, go through this link, they'll be linked to our Emergency Communications Center. So this is a center that's been an incredible resource for us and was founded as part of the Maritime program. It's staffed 24 hours a day by emergency medical technicians, so people who have some medical foundation of knowledge and are also capable of doing triage appropriately. So the operators will notify our physicians of the need for a follow-up visit. We'll be able to access their emergency department record from home and connect with that patient at a time that's convenient for them. So certainly one of our major goals is to improve the ability of patients to follow up. So asking them to be seen within 2 to 3 days when we know that it's really about 2 to 3 weeks or more to see a primary care physician, that's one of the problems that we're trying to mitigate. But it's not the only problem. So you see a number of other goals of the program. We know that a lot of people return to the emergency department shortly after discharge for scheduled visits, like 48-hour wound checks, but also for unscheduled visits. So they're concerned about their symptoms. They want to know if their healing is normal. They're still having we'd like to decrease some of these scheduled and unscheduled visits in order to decrease the length of stay, improve the efficiency of the emergency department, and reduce the number of people who leave without being seen because they're frustrated by the wait times. So those are some of our other goals. We also know that emergency physicians are less likely to admit patients if they know that they have adequate follow-up. So we'd like to reduce low-risk admissions. We've already talked about increasing access. Of course, we'd like to improve the brand of GW as an innovator in healthcare. And we have seen that this program improves patient satisfaction. And certainly, we're charging just $35 for the follow-up visit is less than the cost of an emergency visit. So some more details about the program. Our technology platform is not anything unique because we want it to be something that's readily available and accessible for patients. So we're connecting with patients by FaceTime. For those who have Apple products, we're connecting with them by Skype for Business for those who have Microsoft. Both of those have 25/6-bit encryption, and FaceTime is an end-to-end platform, so that addresses our security and privacy concerns. We also specify that the patients need to be using a secure Wi-Fi network as part of our digital consent process. We've had to develop policy and procedures for referrals from the emergency department in terms of providing the pre-printed discharge instructions, providing guidance for our providers on where is an appropriate setting to take a call so there's minimal distractions, and you can confer that same professional patient-physician interaction as you would in a face-to-face encounter. In terms of referrals and scheduling, we've addressed that. Marketing and education has been a tremendous effort and a tremendous challenge for us. So we've posted advertisements in each of the patients' rooms. So in the time that they spend waiting for results, they can read about our program. We've also invested a large amount of time in educating providers. So we've been going to faculty meetings regularly. We've been going to grand rounds. And we also have someone who stops in each day to sit at the desk and remind docs about the program in order to generate referrals and generate awareness. In terms of documentation, we're using Cerner and Allscripts. And billing, I mentioned that we're charging a $35 flat fee. At this point, it's credit card only when we're not accepting insurance, but we will in the future. DC is fortunate to be one of the many states, now the majority of states, that has parity laws, mandating that any service provided by telemedicine needs to be reimbursed at a similar rate as an in-person encounter. And so I mentioned some of our challenges. In large surveys of physicians, there are a number of concerns that arise when you start to talk about having a telemedicine visit. And so these include concerns about reimbursement, concerns about privacy and security, but by far, the most frequently encountered in our experience are questions of clinical appropriateness and concerns about a lack of training in treating patients in this way. And so the truth is, nobody knows what the appropriate clinical use cases are, and we're trying to explore that and push the limits there a bit. So most people feel comfortable referring urgent care patients to our program, and the majority of our patients come from our urgent care side of the emergency department, and they're of lower triage acuity. We're really only generating at this point about 1% of our patients are referred to the ConnectER program, and obviously we'd like to improve that. The chart on the right is a sign of success for us. So initially, almost 90% of our referrals were from our core faculty group in innovative practice. And as time has gone on, that percentage has declined as we're getting referrals from other physicians who increasingly feel comfortable recommending this to patients. So that's been a tremendous success. In terms of challenges for patients and patient education, this is somewhere where we've also struggled. So despite the fact that we have these processes in place to provide discharge instructions about the program and pamphlets and brochures to educate patients about the service that we're offering, only about 2% of the patients we're referring are following up. And when we've asked them the reasons why, many simply aren't aware that the program exists as an option. And about 40% of those say if they had known, they would have considered it. And we know that from this evaluation of our patients, many are still returning to the ER or following up in the clinics. I think we do have time for this video, so I just wanted to give you a glimpse of where things can go in the future. This is a video from a design technology company called Whirl that took on the challenge of patient-centered care and telemedicine after viewing how trauma care is conducted in the emergency department.
Today in medicine, we deliver care where we feel like it's appropriate, in a hospital, in a clinic, in the back of an ambulance. But in the future, we're going to be delivering care with patients where they might feel it's appropriate.
How are you feeling now?
It's all technology-based, but this human interaction is still very important.
I think what design really does is it starts to spark that side of us that's creative, that's interested in ingenuity, constantly challenging ourselves to think about what adds value to this patient.
Good evening, Mrs. Hillstead. May I please have the last 4 digits of your social security number?
2139.
Thank you. I see you're calling about Charlie, and he has a temperature of 103.
What other symptoms does he have?
Well, he says his stomach hurts. I'm worried about appendicitis or something. Do you think I should take him to the hospital?
We want to have a service that takes patients from defaulting to going to the highest level acuity and stratifies them into other areas of acuity and potentially allows them to never have to leave their home in the first place.
We have a camera, thermometer, blood pressure cuff,
EKG, pulse oximetry,
a little scope. That's pretty cool.
Patients are going to play a larger and larger role in their own care, but experience and relationship is still necessary. That's why people still need medical care and medical professionals. We're going to have to understand how we fit into their care that they want, desire, and need. I think healthcare can use design to help us gain a better perspective of the whole picture of what's going on.
Pick up the phone and call the doc box and consult with someone who has either different or more experience than she has.
I'll continue to monitor Charlie until morning in case it does turn out to be something more severe.
Thank you.
We need to rediscover patients, and we need to find ways to reduce hospitalizations. Trying to find ways that we can help them be healthier is going to require a great degree of creativity.
This concept is just one example of a new care model. But we're at a moment in time in healthcare where we have the opportunity to rethink how we serve patients.
So I just want to leave you with that vision of where things can go. That video is already now 5 years old, and there's all kinds of really, really fascinating technologies that are coming on. As I mentioned, you don't even need to buy this little convenient suitcase with the flu testing and the adjuncts anymore. You can just attach them right to your phone. So I do want to leave you with a few concepts in terms of telemedicine. It has tremendous potential to improve patients' access to care, and more importantly, timely access to care. It's also patient-centered care. And these examples that I've offered you from our telemedicine program and from this design video, these are just 1-2 examples. And I would challenge each of you to think about applications in your local practice environment and in your communities where you can apply telemedicine and expand access for patients. Thank you.